we realized that it was not really moderately emetogenic. So I think the main issue is really watching for symptom management, right? And watching for any toxicity, so kind of the regular chest CT imaging and so on. My impression is that many of us, we already understand the potency of this agent.
Yeah.
And so there will likely be adoption of this. I think that there's going to be some hesitance in terms of how long do we go, and just the relative ease of doing an induction followed by maintenance. So I think that honestly, like the efficacy data is pretty profound, and I think many of us do follow that data and then sit down with our patients and have that conversation about where to go. If we didn't have the patina trial, then it would be very easy, right?
Yeah.
But with patina and just the differences in toxicity and I think overall quality of life, that's where it's going to be more of a kind of a discussion with the patient and so on. But I do feel like at least my community colleagues, I think that many of them have had a lot of experience because we have the DB06, and that's a much larger patient population. Mm-hmm. I would say that if it was a few years ago, it may be a bit more, there may be a little bit more hesitance.
My colleagues and those in the community, I work in the community also, they're excited about T-DXd.
Yeah.
There's some fear about it, but since DB04, there's been some excitement around it. And my only concern is if you're going to use it, you have to pay attention to the population, who you give it to, and their symptoms.
Yeah, and like we said too, sorry, Greg, as we said, it's really important to, follow those patients, and it's going to be different for the clinic workflow.
Yes.
Right? So it's going to require more touching base and really following for that ILD and others. And that's, I felt the same way with like the adjuvant ribo data, right? Because many of these patients you're not seeing after a certain period of time. So that's going to be a big shift.
We talked a lot about ILD. What about nausea?
Yes. So very early from the initial approval of T-DXd, we realized that it was not really moderately emetogenic. It was highly emetogenic. So it got bumped up in the anti-emesis guideline for the NCCN.
What is your experience once it got bumped up?
Yeah, so I do tend to pull olanzapine out. So I'll use like a 5-HT3 and an NK1. And then obviously dexamethasone. I tend to have patients take dexamethasone for a few days after, and then quickly bring in the olanzapine. I don't tend to start it for all patients right away, unless I know that in the past they've had issues with nausea. Then I may say, right off the bat, let's use it as part of the prophylaxis.
But so you do the 3 to 4 drug regimen.
Right. Yeah. I've seen more of that delayed nausea and vomiting. And the olanzapine works beautifully for that. And sometimes even dose reduction.
Yeah, I have to say, the first time I used the drug, when it first got early approval, I was most surprised by the level of nausea.
Yeah.
But once it got bumped up, and we started having appropriate anti-nausea, the 5-HT3, NK1, steroids, at least those 3, and then olanzapine, sort of the nausea is really not as impactful.
Yeah.
And we have patients who have really good quality of life on this regimen.
Right, so I agree.
So yes, and dose reduction is always an option.
Yeah.
All right.